Direct hyperbilirubinemia indicates hepatobiliary dysfunction and always represents pathology in the newborn. We define it as direct bilirubin greater than 1 mg per deciliter when total bilirubin is less than 5 mg per deciliter, or greater than 20% when total bilirubin exceeds 5 mg per deciliter. The pathophysiology differs fundamentally from indirect hyperbilirubinemia. The liver successfully conjugates bilirubin, but excretion is impaired due to hepatocellular dysfunction or biliary obstruction. This explains why phototherapy provides no benefit. Conjugated bilirubin is already water-soluble and processed. Physical findings include acholic or clay-colored stools indicating absent bile flow to the intestine, dark urine from renal excretion of conjugated bilirubin, and hepatomegaly in most cases. These findings help distinguish direct from indirect hyperbilirubinemia at the bedside. The differential diagnosis includes both medical and surgical causes. Biliary atresia represents the most time-sensitive diagnosis, as surgical outcomes correlate directly with age at intervention. The Kasai procedure achieves best results when performed before 60 days of life. Other causes include TPN-associated cholestasis in infants requiring prolonged parenteral nutrition, infections including sepsis and torch, metabolic disorders such as galactosemia and tyrosinemia, and neonatal hepatitis. Each etiology requires specific evaluation and management, making prompt assessment essential for any infant presenting with direct hyperbilirubinemia. Cholestasis in neonates divides into obstructive and hepatocellular causes, with this distinction guiding both diagnostic evaluation and management urgency. Obstructive causes require surgical evaluation and include biliary atresia, the most common surgical cause of neonatal cholestasis. Ultrasound may show the triangular cord sign, though many cases have normal imaging. Cholodoic cysts appear as cystic structures in the porta hepatis region and may present with intermittent obstruction. Bile duct perforation presents acutely with ascites and peritonitis. Hepatocellular causes encompass infectious, metabolic, and inflammatory etiologies. Neonatal hepatitis remains a diagnosis of exclusion with fluctuating bilirubin levels and systemic features. Infectious causes include bacterial sepsis, urinary tract infections, and the torch complex. Each requires specific testing and treatment approaches. Metabolic disorders present with characteristic features. Galactosemia causes hepatocellular injury after milk feeding begins, with reducing substances present in urine. Tyrosinemia produces elevated succinylacetone levels and a distinctive odor. Alpha-1 antitrypsin deficiency affects 1 in 2,000 infants and requires specific testing for diagnosis. TPN cholestasis develops predictably in infants requiring prolonged parenteral nutrition, particularly premature infants. The incidence increases after 2 to 3 weeks of exclusive TPN use, with direct bilirubin rising progressively. Management involves initiating enteral feeds when possible and providing appropriate nutritional support. Biliary atresia involves progressive inflammatory obliteration of bile ducts, affecting 1 in 10,000 to 15,000 newborns. The condition represents a dynamic process rather than a fixed congenital anomaly, explaining why early intervention dramatically improves outcomes. Clinical presentation typically involves a well-appearing infant with persistent jaundice beyond 2 weeks of age. Initial growth and feeding patterns remain normal. Acholic stools develop as bile flow diminishes and hepatomegaly becomes palpable as fibrosis progresses. The combination of direct hyperbilirubinemia, acholic stools, and hepatomegaly in an otherwise well infant strongly suggests biliary atresia. Diagnostic evaluation reveals characteristic patterns. Direct bilirubin elevates disproportionately to transaminase levels. GGT rises significantly, helping differentiate from certain metabolic disorders. Synthetic function remains preserved initially, with normal albumin and coagulation parameters. Ultrasound may show absent or contracted gallbladder, though normal imaging doesn't exclude the diagnosis. Timing drives management decisions. The Kasai protoenterostomy achieves successful bile drainage in most infants when performed before 45 to 60 days of life. Success rates decline sharply after 60 days and become minimal after 90 days. This narrow therapeutic window mandates prompt evaluation of any infant with persistent direct hyperbilirubinemia, early diagnosis essential for optimal outcomes. These infants require immediate referral to pediatric hepatology or surgery for definitive evaluation and management. The evaluation of suspected biliary atresia follows a systematic approach designed to confirm the diagnosis rapidly while excluding other causes of neonatal cholestasis. Each component of the workup provides specific information that guides us toward or away from this diagnosis. Laboratory evaluation begins with comprehensive testing. Direct bilirubin elevation confirms cholestasis, while the disproportionate rise compared to transaminases suggests obstruction rather than hepatocellular injury. GGT elevation helps differentiate biliary atresia from certain metabolic conditions that present with normal or low GGT levels. Abdominal ultrasound serves as the initial imaging study. While the triangular cord sign at the porta hepatis strongly suggests biliary atresia when present, its absence doesn't exclude the diagnosis. Many infants with biliary atresia have nonspecific ultrasound findings. The gallbladder may appear small, irregular, or absent, though a normal gallbladder can still be seen in biliary atresia. Nuclear medicine hepatobiliary scintigraphy using technetium-99 IDA provides functional information about bile flow. After pre-treatment with phenobarbital to enhance bile flow, the radiopharmaceutical is injected. In biliary atresia, we see good hepatic uptake but no excretion into the intestine, even on delayed images at 24 hours. This finding indicates complete biliary obstruction. When initial studies suggest biliary atresia, liver biopsy provides histologic confirmation. Characteristic findings include bile duct proliferation, portal tract expansion with fibrosis, and bile plugs in canaliculi. The degree of fibrosis correlates with age at diagnosis, reinforcing the importance of early evaluation. The gold standard remains intraoperative cholangogram, performed during exploratory laparotomy. This allows direct visualization of the biliary tree or its absence. If biliary atresia is confirmed, the surgeon proceeds immediately to Kasai portoenterostomy. Management of biliary atresia centers on the Kasai portoenterostomy, a procedure that creates a new pathway for bile drainage by connecting the liver directly to the intestine. Success depends critically on timing and meticulous postoperative care. The surgery involves resecting the obliterated extrahepatic bile ducts and fibrotic tissue at the portopatis, then creating a Roux-en-Y jejunal loop that's sewn directly to the liver capsule. This allows microscopic bile ductules at the liver surface to drain into the intestine. Success is defined as achieving bile flow, stools become pigmented, and bilirubin levels decrease. Age at surgery remains the strongest predictor of success. Infants operated before 45 days achieve bile drainage in approximately 80% of cases. This drops to 40 to 50% between 60 and 90 days, and less than 20% after 90 days. Even with successful drainage, many children eventually require liver transplantation due to progressive intrahepatic disease. Post-operative care focuses on optimizing bile flow and preventing complications. Fat-soluble vitamins A, D, E, and K require supplementation due to ongoing fat malabsorption. Ursodeoxycholic acid promotes bile flow and may have hepatoprotective effects. Medium-chain triglycerides provide calories that can be absorbed without bile salts. Cholangitis represents a major postoperative complication, occurring when intestinal bacteria ascend into the biliary tree. Prophylactic antibiotics reduce but don't eliminate this risk. Parents need education about recognizing signs: fever, increasing jaundice, and acolic stools after previously pigmented ones. Long-term monitoring includes regular assessment of liver function, growth, and development. Rising bilirubin, coagulopathy unresponsive to vitamin K, or portal hypertension indicate progressive liver disease. These children require referral to transplant centers for evaluation. With current surgical techniques and immunosuppression protocols, liver transplantation offers excellent long-term survival. though the goal remains preserving the native liver as long as possible through successful Kasai drainage. Metabolic disorders causing neonatal cholestasis share a common thread. They disrupt normal hepatocyte function through accumulation of toxic metabolites or deficiency of essential compounds. Understanding their pathophysiology helps with both diagnosis and management. Galactosemia results from deficiency in galactose 1-phosphate uridyl transferase, causing toxic galactose metabolites to accumulate in hepatocytes. These infants develop symptoms after starting breast milk or formula. Along with direct hyperbilirubinemia, they develop hepatomegaly, failure to thrive, and cataracts. The presence of reducing substances in urine after milk feeding provides a rapid screening clue. Early diagnosis prevents irreversible liver damage and intellectual disability. Treatment simply requires eliminating galactose from the diet. Tyrosinemia type 1 involves deficiency of fumarate acetoacetate hydrolase, leading to accumulation of toxic tyrosine metabolites. These compounds cause progressive hepatocellular and renal tubular damage. Infants present with cholestasis, coagulopathy despite vitamin K supplementation, and that characteristic cabbage-like odor. Elevated succinylacetone in urine confirms the diagnosis. Without treatment, these children develop cirrhosis and hepatocellular carcinoma at remarkably young ages. Alpha-1 antitrypsin deficiency affects 1 in 2,000 infants, though not all develop liver disease. This protease inhibitor normally protects tissues from neutrophil elastase. In its absence, or when misfolded proteins accumulate in hepatocytes, progressive liver injury occurs. The PEAS phenotype carries the highest risk for neonatal cholestasis and later emphysema. Diagnosis requires checking alpha-1 antitrypsin levels and phenotype. Low levels alone may reflect consumption during inflammation. Cystic fibrosis presents with cholestasis through inspissated bile syndrome. Abnormal CF-TER protein affects bile composition and flow, leading to plugging of bile ducts with thick secretions. While meconium ileus raises immediate suspicion, some infants present first with cholestasis. The sweat chloride test remains diagnostic, though genetic testing increasingly serves as first-line evaluation. Infections rank among the most common causes of neonatal cholestasis, with mechanisms ranging from direct hepatocyte invasion to inflammatory bile duct injury. Timely recognition allows targeted treatment that can prevent permanent liver damage. Torch infections each produce characteristic patterns. Cytomegalovirus leads all congenital infections causing cholestasis, presenting with microcephaly, periventricular calcifications, and thrombocytopenia alongside liver involvement. The virus directly infects hepatocytes and bile duct epithelium. Diagnosis requires urine CMV culture or PCR within the first 3 weeks of life. Later testing can't distinguish congenital from postnatal infection. Bacterial sepsis causes cholestasis through multiple mechanisms. E. coli remains the most common pathogen, with urinary tract infections frequently overlooked as a cause. Gram-negative endotoxin directly impairs bile salt transporters on hepatocytes. Additionally, inflammatory cytokines downregulate genes controlling bile acid synthesis and transport. Blood and urine cultures guide antibiotic selection, with cholestasis typically resolving as infection clears. Herpes simplex virus causes severe disseminated disease in neonates. Liver involvement manifests as fulminant hepatitis, with massive transaminase elevation, coagulopathy, and cholestasis. Without high-dose acyclovir treatment initiated empirically based on clinical suspicion, mortality approaches 85%. Maternal history often provides the key. Primary herpes infection near delivery carries the highest transmission risk. Less common infectious causes deserve consideration in specific contexts. Syphilis rates continue rising, making congenital syphilis an important consideration. Hepatomegaly, jaundice, and the characteristic desquamating rash on palms and soles suggest the diagnosis. Parvovirus B19 occasionally causes neonatal hepatitis with cholestasis. Adenovirus and enterovirus can produce fulminant hepatic failure in newborns, particularly those with underlying immunodeficiency. Total parenteral nutrition saves the lives of infants with intestinal failure, but prolonged use exacts a price on the liver. Understanding risk factors and prevention strategies helps minimize this complication in our most vulnerable patients. The pathophysiology involves multiple insults to the hepatobiliary system. Lack of enteral feeding eliminates hormonal signals like cholecystokinin that normally stimulate bile flow. Bacterial overgrowth in the unused intestine produces endotoxins that reach the liver via portal circulation. TPN components themselves, particularly manganese and phytosterols in lipid emulsions, directly injure hepatocytes. Omega-6 fatty acids in traditional soybean-based lipids promote inflammation through pro-inflammatory mediator production. Risk factors compound in our smallest patients. Prematurity tops the list. Infants under 1,000 grams birth weight face the highest risk due to hepatic immaturity. Duration of TPN correlates directly with cholestasis development, typically appearing after 2 weeks of exclusive parenteral nutrition. Sepsis episodes accelerate liver injury through additional inflammatory insults. Lack of enteral feeding removes protective factors while allowing bacterial translocation. Prevention strategies focus on minimizing TPN exposure and modifying its composition. Early enteral feeding, even trophic amounts at 10 to 20 milliliters per kilogram per day, maintains gut integrity and stimulates bile flow. Cycling TPN over 12 to 18 hours, rather than continuous infusion, allows hepatocyte recovery. Fish oil-based lipid emulsions like Omega-VEN provide omega-3 fatty acids that reduce inflammation and may reverse established cholestasis. Limiting soybean-based lipids to less than 1 gram per kilogram per day decreases phytosterol exposure. Management requires balancing nutritional needs against progressive liver injury. Advancing enteral feeds remains paramount, though intestinal failure often limits progress. Treating bacterial overgrowth and preventing line infections reduces additional hepatic insults. Ursodeoxycholic acid may improve bile flow, though evidence in neonates remains limited. When cholestasis progresses despite optimization, referral to intestinal rehabilitation programs allows coordinated care. Some infants require combined liver-intestinal transplantation, making early recognition and aggressive management essential for preserving transplant candidacy. Total parenteral nutrition saves the lives of infants with intestinal failure, but prolonged use exacts a price on the liver. Understanding risk factors and prevention strategies helps minimize this complication in our most vulnerable patients. The pathophysiology involves multiple insults to the hepatobiliary system. Lack of enteral feeding eliminates hormonal signals like cholecystokinin that normally stimulate bile flow. Bacterial overgrowth in the unused intestine produces endotoxins that reach the liver via portal circulation. TPN components themselves, particularly manganese and phytosterols in lipid emulsions, directly injure hepatocytes. Omega-6 fatty acids in traditional soybean-based lipids promote inflammation through pro-inflammatory mediator production. Risk factors compound in our smallest patients. Prematurity tops the list. Infants under 1,000 grams birth weight face the highest risk due to hepatic immaturity. Duration of TPN correlates directly with cholestasis development, typically appearing after 2 weeks of exclusive parenteral nutrition. Sepsis episodes accelerate liver injury through additional inflammatory insults. Lack of enteral feeding removes protective factors while allowing bacterial translocation. Prevention strategies focus on minimizing TPN exposure and modifying its composition. Early enteral feeding, even trophic amounts at 10 to 20 milliliters per kilogram per day, maintains gut integrity and stimulates bile flow. Cycling TPN over 12 to 18 hours, rather than continuous infusion, allows hepatocyte recovery. Fish oil-based lipid emulsions like Omega-VEN provide omega-3 fatty acids that reduce inflammation and may reverse established cholestasis. Limiting soybean-based lipids to less than 1 gram per kilogram per day decreases phytosterol exposure. Management requires balancing nutritional needs against progressive liver injury. Advancing enteral feeds remains paramount, though intestinal failure often limits progress. Treating bacterial overgrowth and preventing line infections reduces additional hepatic insults. Ursodeoxycholic acid may improve bile flow, though evidence in neonates remains limited. When cholestasis progresses despite optimization, referral to intestinal rehabilitation programs allows coordinated care. Some infants require combined liver-intestinal transplantation, making early recognition and aggressive management essential for preserving transplant candidacy.